Now is Dr. Julian Eason to hear about present and the future of hydrocephalus in preterm. We are going to think like not only the meticulous neurologist, but also like the decision maker neurosurgeon. I hope we'll close the gap between the islands, neonatology, neurology, and neurosurgery. Thank you.
بصوا يا جماعه احنا وزعنا evaluation form دلوقتي especially اللي محتاج شهاده الكريدت اورز بتاعت الامريكان اسوشيشن اوف ريسبيراتوري كير بليز هنملى الفورم كل واحده في السطر الثالث فيها اسم المحاضره فهتلاقيهم الثمان محاضرات الاكريديتد فمن فضلكم مخصوص اللي عايز الشهاده الاكريديتد لازم يملى الايفالويشن فورم. شكرا.
يعني كل صفحة يا جماعة هتلاقوا فيها عنوان المحاضرة بادية من يونيت سيبكم التاريخ لأن التاريخ تقريبا مكتوبة غلط. شوفوا بس عنوان المحاضرة والإيفالويشن لكتشر باي لكتشر عشان الكريدت اورز. اوكي شكرا جزيلا. جوليان.
Okay, assalamu alaikum, good morning everybody. Nice to see you all again. This morning I've got a couple of talks to give on basically involving neurology. This one really involving the neurosurgeons. And an issue that I think many of us have to deal with is the management of post-hemorrhagic hydrocephalus and how we do it. And I'm just going to give you a run through of some evidence and then richly what we do practically in our unit when we come across this problem. And I'll just start by, in addition, I'll just saying that I fully appreciate all the pediatric neurological and neurosurgical input we get. They are very good friends of ours. Evidence-based guidelines, the management of post-hemorrhagic hydrocephalus. A paper back in 2014, what are the optimal treatment strategies for post-hemorrhagic hydrocephalus? Well, about 7 recommendations about how you can temporize the problems when you have hydrocephalus. And we'll talk about them in a little bit of detail. So we can have ventricular access device, external ventricular devices, we can have subgaleal shunts, lumbar punctures, all various types of treatment that many of us have probably seen or tried or attempted on the neonatal unit or perhaps in the operating theatre. There are various one-liners that people talk about. Well, I prefer the subgaleal shunts because they reduce CSF aspiration compared to ventricular access devices. Therefore, that's my preferred type of practice. And others will say, well, we use serial LPs, and some people will not be happy with the use of serial lumbar punctures, reducing the need for shunts. So there's all sorts of different ideas and practices and comments that people have. So what we do know is that the thrombolytic agents, the TPA, the uricinases and streptokinases are really not recommended. There is no point in trying to break up a clot that has occurred in the brain. It simply it doesn't work. It's dangerous in the preterm infant, and it's not something that is recommended because it doesn't alter the need for shunt replacement and sometimes has a lot of complications. Once again, going back in time, I always like to go back in time. Back in time when we were looking at furosemide and acetazolamide as medications to try and reduce the amount of CSF produced. We know that that is now no longer an ideal practice, and in fact acetazolamide having many adverse consequences. So when I look back over the past 30-odd years or so, we have changed our ideas and certainly changed our practices about what we do with hydrocephalus. So what's the optimal treatment strategies? Timing of shunt replacement. So there actually is not enough evidence to recommend a specific weight or CSF parameters to look at the timing of a shunt. If you look at the neurosurgical practices from different hospitals and in fact all over the country and around the world, each neurosurgeon has a different threshold and a different thought about when they should put in a shunt or an access device, and they will all use different devices. They will have different parameters of when they feel comfortable or not comfortable about undertaking this. And then, of course, you might have heard of third ventriculostomy. This is certainly a trial that was being undergone in the UK, and this is something that the evidence is saying that is something that is not being advocated at the moment, although people will talk about ventricular and ventriculostomies. So, if we look at infants with very low birth weight, they have a high risk of IVH, and we know in our NICUs, and forgive me if I don't know exactly the type of babies you're getting, but in the UAE we have fairly unregulated, uncontrolled IVF. I have multiple pregnancies at 23, 24 weeks, triplets, almost every 1 to 2 weeks. Another 3 of these babies, or 2 or 1, depending on how many survive the delivery, will come into my unit. Mothers, we have a lot of gram-negative carriage, we have a lot of infected mothers with chorioamnionitis, and I have a lot of very sick babies, and unfortunately as a consequence we see a lot of IVH. And despite our best abilities to try and look at this and try and reduce it, the rate that we certainly have in Abu Dhabi in my unit is relatively high compared to a Vermont-Oxford average. So I can't put my hand up and say I'm great, none of my babies get IVH because my care is fantastic, because actually the quality of baby I get is often a little bit dubious. So extremely low birth, depending on which part of the literature you read, extremely low birth weight infants, on average 33% getting an IVH when you look at this paper here. And in 13% of those, either grade 3 or grade 4, and we can talk about types of grade and how they're graded, because I suspect some of us do it a little bit differently. And approximately 3% in this series was saying would need a shunt at some stage. So we probably know these pictures. Maybe it'll be a bit better if one of the lights go down, but I think you can see a big black hole there, probably a picture that many of us have seen on our units when we pop on a head scanner. And you don't have to be a great sonographer to be able to see this. A simple window on the anterior fontanelle, and you can see hydrocephalus, usually as a result of intraventricular hemorrhage. Now, of course, there are plenty of other reasons for hydrocephalus. We know you can be born with hydrocephalus. I see plenty of babies with aqueduct stenosis, etc., etc. But ordinarily, I'm talking here about post-hemorrhagic. So, when do we intervene? When do you intervene? When do I intervene? I suspect we all do it a little bit differently. What about symptomatic infants? What if the baby is too small or unstable and you really can't put in a shunt because the baby just isn't going to be fit for that procedure? So all sorts of things you need to be discussing with your friendly neurosurgeon. So what can we use? Well, we can use ventricular reservoirs. And one way is to pop in a reservoir so that fluid can be removed thank you very much, at various intervals. Let's go back so you can see that a bit better. Of the classical post-hemorrhagic hydrocephalus, here seen on ultrasound, and here seen on MRI. You don't necessarily need anything more detailed than a very good ultrasound, but here's our first conflict with our neurological colleagues, is that they always want an MRI. And an MRI will probably alter, you can talk to the surgeon about this, but usually in high detail, the ultrasound will give you just as much information as the MRI in this situation. And an MRI for me means a baby has to go on a journey across town and is extremely disruptive, and if the baby is not the greatest of condition, I don't particularly want to put the baby in the back of an ambulance for an MRI when I can get a beautiful picture with an ultrasound. That's just a practicality that you may all recognize or not recognize. We can have external ventricular drains, which we can chat about, and what I can tell you in our practice is that we will not have an EVD on our NICU. If a baby or really needs an EVD, then that baby will go to a PICU and be looked after by the neurosurgeons on site. Because we're off site and because there's extremely high risk of infection, and unfortunately my unit is not what I would regard as a unit where I can guarantee sterility, and I have no isolation rooms for this, then we do not have EVDs on our unit. Subgaleal shunts will have a look at them, but it's not something our neurosurgeons will do. Serial LPs is interesting. We tend not to do serial LPs. We can do an LP for a diagnosis, but ordinarily, because, and we have a debate about this, we don't, because the babies can often be a bit compromised with the position, with the holding, with the desaturations, with the fact that they can fail and you can have multiple attempts. We tend not to do serial LPs initially before a shunt is placed. We don't use IV thrombolytic agents, acetazolamide, furosemide, or any other external devices. What we do is we do ventricular tapping with an agreement with our neurosurgeons. And I'll explain that in a little bit more detail because it created a bit of debate. So our surgeons are very keen on getting in an Ommaya reservoir. And the reservoir allows us to buy time before a shunt is deemed absolutely necessary. So we ordinarily will do ventricular taps until an Ommaya reservoir is placed, and then we will tap through the Ommaya reservoir. And because of this, we can allow aspiration, ventricular decompression, we can lower intracranial pressure very, very easily, and it's a very simple, easy device to use. And this is our preferred device from our neurosurgeons. If a baby is not going to have a shunt, but has an enlarging head circumference. So from this study here, repeated aspiration of CSF did not significantly increase the risk of infection, and we have not, as far as I'm aware, had a case of ventriculitis from this. They didn't reduce the need significantly for shunt replacements, so usually you will go on to perform a full shunt. But what our surgeons were more interested in is this comment: it reduces the morbidity and mortality rates associated with EVDs. Now, I'm not one for anecdotes, but I'm going to give you an anecdote. We had a parent who absolutely insisted, having read the literature themselves, that they would have an EVD on their baby. Our neurosurgeons disagreed, and we disagreed, and said it was the wrong thing to do in this particular child. For whatever reasons, it went up through the government. The government came down to us and said, you will give this baby an EVD. That's kind of how it works sometimes in the UAE. And so we said, well, not on my unit. It's going to have to go to PICU. This baby went to PICU, had an EVD, was there for weeks and weeks, got dreadfully infected, horrible ventriculitis, and 5 days after the baby was eventually discharged, about 4 months later, the baby was brought back in dead into the emergency room, and supposedly just having suddenly arrested. Very, very difficult case to deal with. But the bottom line is, even with one EVD that we said we didn't want, the infection that the baby got on the PICU and the ventriculitis was horrendous. Now, that's just an anecdote of one case, but the evidence does show you do get far more infections with the EVDs. They have to be beautifully looked after, and I just can't do that and won't have it in my unit. And because there is ordinarily no space in our PICU or neurosurgical unit to look after these infants, that's why we don't do EVDs. You may do something different, of course. So in these articles here, the EVD obviated the need for VP shunt placement in fewer than 1/3 of the infants treated. So it's not going to stop you. It's not going to stop you getting a shunt, and more than 50% of preterm infants with post-hemorrhagic hydrocephalus did require a permanent shunt during removal of an EVD. 95 out of 132 survivors required a shunt. An EVD, the idea was that some babies or some infants with an EVD may not need a shunt, less so than the studies on the Omaha reservoir, but ordinarily the complications and the difficulty looking after these infants is something that our neurosurgeons have chosen not to do ordinarily in our population. We also don't use subgaleal shunts. They're not pretty, are they, really? But it does reduce the daily need for CSF aspiration because it's all there, very, very visible, collecting in that compartment there. But they do have a purpose. There's evidence that they can decrease the need for permanent shunting. But this is also something that our neurosurgeons also have opted not to do. It's never pretty. It's not cosmetically great while the baby has the subgaleal shunt. But ordinarily, it is an option, but not one that we undergo. Serial lumbar punctures. Well, LP ordinarily isn't recommended to reduce the need for shunt or avoid the progression of hydrocephalus in premature infants. And the lumbar puncture has been shown to neither predict nor prevent the need for a permanent VP shunt, and repeat LPs may cause or contribute to shunt infection from this article here. But LP itself, ordinarily, if you have a communicating hydrocephalus, is fine, you know, in a one-off. We will do the occasional lumbar puncture. It's just not something we're doing routinely to relieve the pressure. We would ordinarily, as I said, and I'll come on to use a ventricular tap, which sounds a bit more invasive, but in our practice is not. So, although lumbar puncture technically is easy, you have a very sick baby. This isn't a very good position for them to be in, especially if they're ventilated and very unwell and very labile. It's a procedure that takes time. It's a procedure that doesn't always go well, and therefore the odd lumbar puncture is fine. But if you need to do many, we tend not to. Now, we do know that very, very occasionally, if a baby appears to be developing hydrocephalus or post-hemorrhagic hydrocephalus, very occasionally you can do 1 or 2 lumbar punctures, and then there seems to be an arrest of the hydrocephalus. And so that's why we ordinarily do a few taps, be it ventricular or lumbar puncture, before we'll go into looking at whether we need anything more regularly, because sometimes, just sometimes, that hydrocephalus arrests. But it's very hard to predict in which baby that's going to occur. So what about early versus late intervention? So early treatment of the hydrocephalus is safe and effective regardless of whether LP or reservoir placement was used. So actually delaying the need for putting in a shunt or putting it in earlier if a baby is well doesn't appear to make a great deal of difference. The timing, if the baby is well, doesn't appear to be an issue, so they can go in at many stages of life and be fine. Early intervention, however, associated with a reduced requirement for VP and reduced risk of moderate to severe disability. So the earlier you intervene, if you are suspecting you might have post-hemorrhagic hydrocephalus, and we'll look at the graphs in a second. If you do begin to do some taps and you take off a little bit of fluid, then just occasionally you might not need your VP shunt, because the VP shunt itself, once you've put one in, of course, it's for life. You're never going to take it out, and it's going to need multiple extensions. So the decision to actually put one in is a big one, because it is going to affect the rest of your life. And all interventions, really, whatever you do, is ordinarily fairly safe, because many of these interventions are practiced very differently by different people around the world, and everybody will have their favorite type of intervention. So As I've said before, we don't recommend the thrombolytic agents. And the drift procedure, I don't know whether you know about the drift procedure, drainage, irrigation, fibrinolytic therapy is not recommended. The drift surgery was designed in Bristol in the UK, and ordinarily babies were sent up, babies were sent in with hydrocephalus to this referral unit to see if they were qualifying for drift. But the drift didn't reduce shunt surgery or death, and actually there was associated with a secondary IVH. So the drift study was stopped and they brought out drift 2, but it doesn't look as if the drainage and irrigation of any of the bleeds is a real way forward in the treatment of post-hemorrhagic hydrocephalus. And in fact, the referrals to Bristol, to the hospital now to have this done, there was also one centre in Norway that joined the study, is really not taken off around the world. And so drift is something you may have heard of, but drift is really not going to be the way forward for the treatment of post-hemorrhagic hydrocephalus. 44% of these infants in the drift group died or required a shunt, compared with 50% of infants who received standard treatment. Seems okay, it wasn't statistically significant. 35% of preterm infants in the drift study had a secondary IVH, compared to 8% who received standard. So that was a concern. And therefore the intraventricular injection of the streptokinase is really not shown to be effective. So ordinarily we can say still not routinely recommended, and remains experimental. The acetazolamide and furosemide, really not recommended and has no place in management anymore. Higher risks of neurological complications, morbidity and mortality, and have nothing to do with the rate of shunt replacement. So here was a drug, and certainly I can't think of how many years in the 80s when I was training and how many babies we would put on acetazolamide. Many things that we've done in neonatology in the past and probably now are causing harm, and some of them we won't know that we're causing harm, but we have certainly caused a lot of harm to our babies. And the timing of the shunt placement, so basically there isn't a CSF parameter. You probably know your surgeons will want the lowest level of protein. If your protein's high at 18 grams, they won't touch the baby, they want it to come down to 1 or 2 grams. But in actual fact, there isn't a level that's deemed correct before you put in a shunt, because there are various shunts and shunt pressures and shunt valves that you can put in depending on the tenacity and what's in your CSF. Ordinarily, there have been a number of studies. One study saying, well, actually after 1,500 grams it was quite safe, and there were no additional complications. And the CSF cell count, protein and glucose level, really not statistically related to shunt failure. That doesn't appear to be a good correlation. It would seem logical if your protein is very high and your CSF is sticky, then it's going to block a shunt and get a bit gooey. But that's the intuitive brain thinking that. It's interesting that in practice that hasn't shown to be the case. But most people will want a low. Most surgeons will certainly, that I know, ask for a low protein or won't consider connecting a shunt until they have low protein. So this is the picture of the third ventriculostomy. You can see it's quite invasive as you come through with the trocar. So the endoscopic third ventriculoscopy coming down here and trying to open the third ventricle so that there is a better flow of the CSF around the brain, but this there is no evidence really to say that this is helping any baby with post-hemorrhagic hydrocephalus. So another procedure that's gone by the by. A lot of procedures that we've done in the past go by the by. My analogy would be PDA ligation. I've been to a number of hospitals now that haven't ligated a PDA for 5, 6, 7, 8, 9, 10 years. When I consider what we used to do 20, 30 years ago, where you had to ligate a duct, and now we just, well, certainly in our practice in Abu Dhabi and in the UK, almost never ligate a duct. Times have changed, and we used to do a lot of procedures neurosurgically as well, which we just don't do anymore. So it seems that we're becoming less invasive, and maybe that's a good thing. Just some evidence on endoscopic third ventriculostomy. There's a number of papers from El Gamal, Lapina, and Peretta really looking at various studies and showing that that you can do it, but it really hasn't made any difference. So an invasive procedure, if you don't need it, my view is don't do it if it doesn't make any difference. Leave well alone. I tend to hide babies from surgeons most of the time. I don't know what you do. I don't like them being chopped open unnecessarily. So it would seem wise to be conservative, therefore, to reduce the risk of iatrogenic damage, because we do cause damage ourselves. And repeat, what we tend to do is repeat measurements of head circumference, look at just feel the fontanelle, and look at the baby's neurological status, and then we will routinely scan. So ultrasound is something that we're using quite a lot. When it comes to head circumference, ordinarily, here's another thing about growth charts. I don't know what growth charts you use, but when I first went to Abu Dhabi in 2012, we were using, everything was copied from the USA. So we were using American growth charts. Once we've switched to WHO, none of my babies are now tiny and falling off the centiles and grossly abnormal. Far more babies are now normal, because the WHO charts are very, very different. And I know each country produces their own chart, but I think if you don't use your own chart, the WHO is a far, far better estimation of what a baby should be, rather than comparing it with one population. And we have UK charts and WHO charts. And there are differences, plenty of differences. And what the WHO charts allow you to do is allow babies to be small, allow babies not to be growth restricted, allow babies not to be deemed abnormal when they're abnormal on a Western plotted chart. And the same goes for head circumference too. So it's very interesting to see which chart you're using, and I think that's an important thing. Ordinarily, we would measure a head twice weekly, plotted on a growth chart. And our surgeons are obsessed with this 1.5 centimeters. They feel that 1.5 centimeters a week, then give us a call. But unfortunately, 1.5 centimeters, people forget what the measurement was the previous week, or they just look at the last one. And so sometimes it's not the most accurate thing to do, but ordinarily, that tends to be something to alert them. I'm more interested in the plots into what's happening with the baby is when the head starts going above the centiles, and we'll have a look at that. I can find that arrow. We do measure the ventricles. Now, there's something called the ventricular index, but some people do measure it very differently, as you know. It's the distance from the falx to the lateralmost aspect of the lateral ventricle. So you take it from the falx and you take it to the side of the ventricle. But not everybody does it the same. I see measurements going up here, I see measurements going down here, I see everybody doing something different, and then ordinarily you're meant to take it at the level at the beginning of the third ventricle, and I see cuts where people haven't found the third ventricle, or the third ventricle is so dilated it's very hard to distinguish, and so you're not measuring continuously in the same place. So although the VI is a nice thing to do, it actually isn't always entirely accurate, and it really needs the same person to go back and do the same VI each time because of the interoperator differences. And we know we all do slightly different things. So I think the ventricular index is useful. This is the measurement ordinarily we're looking at. Now, true, you get some amazing, bizarre type shaped ventricles which can make it a little different, but your consistency of where you're measuring when you can measure left and right is what's required, and therefore I would suggest the same operator does the measurement, because it's very helpful. And we have these charts, the VI charts, that you can get anywhere off the net at various gestations, and this is the 95th centile, and ordinarily most people are concerned when a baby, certainly when it goes over the 95th centile, and once you hit 1 or 2 standard deviations above, we are really dealing with hydrocephalus. And it's a very nice way to plot, rather than just on a standard growth chart, if you use your VI chart as well. So what's the current practice in Abu Dhabi, just to let you know what we do? We ventricular tap. And now you might think, well, isn't that going to cause infection? Well, not in our practice, I'm pleased to say. We can do an initial LP and sometimes, but if a baby is developing hydrocephalus and we have tapped that baby more than 3 times, or the baby is beginning to be needing tapping more than twice a week, then our surgeons will come in and look to see if the baby is suitable for replacement of the Ommaya reservoir, so we don't have to keep doing the ventricular taps. We're lucky in that my doctors are very used to doing this, and so they're very happy to do ventricular taps. It's a very, very simple thing to do. It's far more successful than LP. The babies tolerate it really well. And it's a simple sterile technique, and we simply use a blue butterfly and take off either 10, 15 or 20 mils per kilo, depending on the situation we're in with the baby. Routinely 15 mils per kilo, but in some babies we'll take 20. What I always find very interesting is the neurosurgeon comes along and he pops the needle in and he'll take 30 mils per kilo off just because he was just enjoying himself so much. And that seems to be okay by them, but they only ever recommend us to take a maximum of 20, but a neurosurgeon, of course, being a surgeon, feels much more comfortable and will take off 30 mils. So I've seen huge amounts of volumes, but don't forget, if you take too much off, you can collapse the brain, you can get subdurals, and the babies will get apnea. So you need to be a little bit careful about being cavalier about taking too much off. So I tend to go up to a maximum of 20 per kilo, just so that to reduce any symptomatology. So we go in, we find the midline, we find the fontanelle, and we go 2/3 to the right or 2/3 to the left. And the nice bit that I like telling my doctors is put your needle in and aim for the eye. And in they go, aim for the eye, and out comes your fluid beautifully. Very rarely, unless you've got a compartmentalized or segmented hydrocephalus, very rarely does it not work. Then we'll put in the Ommaya when the surgeons have said, yes, enough is enough, we agree, the baby needs regular tapping, and then they'll decide at what stage, if and when the baby needs a shunt. So CSF tapping removes the pressure, removes the protein and blood, and clears the CSF pathway. So often with regular tapping, the CSF becomes clearer and clearer as the bloody CSF begins to disappear and it's replaced with fresh. There is a theoretical risk of introducing infection. Now we haven't, but I'm not saying we won't. And that's why some people prefer LP, because they say there's less of an infection risk. In our practice, we're very happy with the ventricular shunts. People talk about the needle track lesions, and we must be damaging the brain. There's no doubt on ultrasound, when you scan where you've done multiple ventricular taps, you can see your needle track lesions. But that's usually where the Ommaya shunt goes. I can't tell you what that may or may not mean in the long term. It's just something you can see, and something will quote to me and say, someone will say, I don't do LP, I don't do ventricular taps, I do LPs because you're leaving needle track lesions. Well, I know I am, but I don't know how harmful, if at all, that is when you compare it to the size of a shunt that goes in, which is massive, and there's a huge chunk of brain that is being divided when the actual Ommaya and the shunt goes in. The needle is very small. So I don't know the answer to that. It's an argument I hear, but there's no evidence either way that one is that is definitely causing harm. It just is causing something. No evidence that early tapping reduces the risk of a poor neurodevelopmental outcome, shunt dependence, or death. Removing the CSF is reserved for cases where there's symptomatic raise, and many infants need a few, if any, CSF taps. Sometimes you can get away with just a few, and it all seems to stop, which is very nice indeed. Subcutaneous reservoirs, the Ommaya reservoir is what we tend to use once we're regularly tapping before the surgeon wants to put in the VP shunt. So when do we do this? Well, if we're tapping 3 times a week, we'll get an Ommaya, avoiding needle tracks. We'll put an Ommaya in. Reservoirs can be tapped up to 3 times a day, but we normally do it every other day. Removal of CSF can be intermittent or continuous, and it's aseptic. So very interestingly, you can almost convert this into an EVD, and very occasionally, when the CSF comes out very, very slowly, we attach the butterfly to a bag and we'll allow it to drain for an hour if it just doesn't come out very quickly. So, but ordinarily, we just take out the 15 to 20 mils per kilo, end of story. And that's what we do. So, as I say, ideally here 10 to 15, we will go up to 20 occasionally, aseptic technique, and obviously frequency depends on your clinical examination, the size of your head circumference, baby symptomatology, and your ultrasound scan if you are doing them. So acceptable weight for on average, we've heard that it can go down to 1,500, but usually our surgeons like a baby over 2 kilos. And they say that there's a few more wound healing issues in the smaller babies. It's doable, but they prefer 2 kilos. They like the CSF protein less than 200 milligrams or 2 grams per liter. And obviously not infected. They will not want any baby to have NEC or intra-abdominal problem before they're thinking about putting in a shunt. Clearly the worst thing that can ever happen when a VP shunt is finally connected is actually getting an infection. Once a baby gets a VP shunt infection, it seems to be a problem that just goes on, and you can be very unlucky if a baby gets an infection with the first placement, because it then seems to dog them for many, many years. So, conclusion, many different types of treatment options. Subgaleal shunts are said to reduce the need for daily CS aspiration compared with the ventricular access device, but my surgeons don't do that. The routine use of LP ordinarily is not recommended to try and avoid the need for shunt placement. Thrombolytic agents, no. Acetazolamide and furosemide, no. Timing, we just don't know when. It's not enough evidence, therefore that's something you decide with your surgeons and yourselves as neonatologists, pediatricians, as to when you want to put a shunt in. And at the moment, the third ventriculoscopy has not proven to be the magic bullet that's going to help these infants. So, ordinarily, post-hemorrhagic hydrocephalus, we basically do ventricular tapping, put in the Ommaya, and then work out when to do the shunt. And therefore, after treatment and follow-up is, of course, with neurology, neurosurgery, etc., if these babies have any other neurological conditions. Thanks very much indeed.
Thank you, Dr. Julian. We'll just have a few questions because we are run out of time. First, I have a comment, please. I do agree with you to keep away from ventricular shunts.
From which shunt? From
ventricular shunts. Ventriculoperitoneal or whatever. It is a disaster for life. Second, third ventriculostomy is by far better regarding the long-term outcome. But it needs a balloon third ventricle, as I mentioned. But it is safer. A recommendation in our practice, the neurosurgeons use or abuse CT scans for follow-up. Because we need to spread that cranial ultrasound is safe and can be used for follow-up up to the age of 1 year.
Yeah, I have a big problem with CT scanning. Our pediatric neurologists and neurosurgeons order a lot, and the radiation to the brain, I think, is frightening, and I don't think they're always necessary. So this is one of my conflicts with them, in that I don't like CT scans, or I mean, CT scan or MRI has to leave our hospital for an investigation. Yes, you're right. The CT scans are ordered, in my view, far too frequently, and the ultrasound is great. So it is an area. There's a lot of evidence of harm to the brain of CT scanning under the age of 2, and I'm very wary about it. But it is something that the pediatricians will ask for a lot in our preterm infants, and it's difficult. It's an area where I have an impasse. Our surgeons simply don't do third ventriculostomies, so they haven't given it to us as an option. So I'm fully accepting that others elsewhere will perform that procedure. It's simply something that our 2 neurosurgeons are not skilled or trained in, and therefore have chosen not to use that option. So the third ventriculostomy, accepted, certainly has advantages, but it's not something that is being given as an option to us. Yeah, thanks.
One more question, please.
Okay, thank you so much. Thank you for the nice lecture. I would like to ask you, the neurosurgeon is the one who do the ventricular tapping, not the neonatologist?
Oh, no, purely neonatology. Yeah, we don't have any. Nobody lives in our hospital apart from neonatologists. No, it's a purely neonatologist. In fact, all my specialists consult anyone. It's so normal for us. It's a routine procedure.
Okay. The next question, please, that about repeated lumbar puncture. You said that it produces less infection and does not produce needle track lesions. So why, clearly, why do you do not recommend, and what precautions you take while you do this serial lumbar puncture, and the same amount and the same frequency as ventricular tapping? A comparison between lumbar puncture and...
Well, I think I'd just say to you practically, if I'm doing 3 taps a week on a baby with gross hydrocephalus, and I want to take 15 mils per kilo, then to hold that baby in a position to get 15 mils per kilo for a period of length of time, it could be ventilated on inotropes, can be very unwell. The LP is the babies desaturate, become hypotensive, and get very unwell. So ordinarily, a ventricular tap, they're in exactly the same position. You're simply cleaning the head, popping a needle in, taking a needle out. It is so atraumatic. It is so much easier. And therefore, that is why we've gone for ventricular taps. Now, there's no evidence of increased infection either way in LP or ventricular tap in our experience, and therefore, simply for practical reasons, we don't do serial LPs. Now, if it's a non-communicating hydrocephalus, you can't anyway. So that rules out that group of babies. So ordinarily, we just don't usually do it. And that's our choice, because it is far less traumatic for the infant, and it's very quick and simple to get 20 mils per kilo from a ventricular tap. It's time, I think time and upset to the baby. No other reason really. But if it's communicating, of course you can do an LP. Of course you can. That's just not our practice.
Okay, thank you so much.
No problem.
Okay. Professor Tariq? The last question, please.
Thank you very much for your excellent presentation. I have just 2 questions. First, do you give antibiotic after ventricular tapping or not? Sometimes we give vancomycin or gentamicin after the tap. The second one is a little bit away from the lecture. Can we do an LB for a baby on a ventilator if you are suspecting meningitis? Or would it be much safer to delay it till the baby is extubated?
Okay, first question. No, we give no prophylaxis because it's a sterile procedure. And unless you're giving are you giving the vancomycin or gentamicin intrathecally?
No. Intramedullary, yes.
Oh, so it's not going to get into the brain anyway. So the vancomycin, gentamicin peripherally is not going to clear anything in the if you have a CSF infection. It has to be intraventricularly. So no, we don't give because it won't penetrate, and there's no reason to. It's a sterile procedure, so we wouldn't cover with antibiotics. If anything, I'm still with our antibiotic stewardship trying to reduce the amount of antibiotics we use, and we've had a lot of success, but there's still too much antibiotic used, I think, in neonatal practice, and we're trying to dramatically decrease it. And in fact, we have. So no, the answer to that one is no. The second question about. Sorry, I'm getting old. The second question was...
Can we do LB for a baby who's suspecting meningitis? If he's ventilated?
Well, we do. Yeah, we LP on the ventilator, yeah. We would routinely... my biggest concern is that if you delay an LP and a baby's had antibiotics, whenever you do the LP, whether it be a week later, 2 weeks later... I mean, we don't do repeat LPs after we treated for meningitis. That's a phenomenon that is never... It's not common in European practice. If you diagnose, we never do a follow-up LP to see if the CSF's clear. There's no evidence for that at all. I know people do it, but we just don't do that. We've got an organism and we treat it, and the baby gets better clinically, and we'll treat for 2 or 3 weeks depending on the organism. But if you're already treating with antibiotics and then you do an LP a week later, it's always going to be sterile. So the only thing that can help you is the cell count. So you've got to guarantee that LP is atraumatic. Now, the trouble is if the baby's had an IVH, that it may be full of cells anyway. So you then get your cell count and you say, well, is that because the baby's had a bleed, or is that because there's an infection? I don't know. So my view is you do the LP as early as you can, and ideally prior to antibiotics, so you've got a proper culture. Otherwise, if you're in any clinical doubt, and you have an organism peripherally, or and you're worried that it might be meningitis, then you would treat for the meningitic length of time. We do LPs later that are delayed in a very, very sick baby. We'll do it a week later or 3 days later, but they're not that helpful, simply because they're sterile, and then it's a guess. It's easy if the cell counts are almost non-existent, then you just say, oh, there's no meningitis. But if there are some cells there, then you just have a debate of, do I treat this baby for 10 days or 21 days? So it's not an easy thing to do, but I always tell my docs, if you think a baby might have meningitis, you do the full septic screen. You don't wait and then ask me the following morning on the ward round, do we need an LP? Because the baby's already full of antibiotics. You do it now. And then my CSF culture is very, very valid. So I take your point. Some babies, you can't do it. It may help later on, but once again, I think it's a judgment call as to whether your baby is responding. And it isn't always easy. There are some babies I just don't know whether to continue the antibiotics for 3 weeks or not. So I find that one hard to answer. From my point of view, any baby on a ventilator, if they're just ventilated, of course, I will LP them straight away. If they're sick and on inotropes and very fragile, then we will write in the chart too unwell for a lumbar puncture. Then we never know how long to give.
Full septic screen if we're suspecting sepsis, early or late sepsis.
Any sepsis.
Any sepsis.
Yeah.
Okay. So this including suprapubic lumbar puncture?
No, we don't do no. I mean,
just LP and blood culture.
No. Suprapubic would be very unusual. I mean, to get a urinary tract infection in a preterm infant, it's tiny. I mean, we never do a suprapubic unless I have an older baby, like a PICU baby, or a baby that's been with us for weeks and weeks. I mean, the suprapubics that you do are almost in 99% sterile, simply because UTI is incredibly unusual in a preterm infant. Loads and loads of contaminated catheter and bag urines. I mean, they're awful because they're contaminated. So I would only ever do a suprapubic if I wanted urine. No, my septic screen on a baby who I'm considering has neurological or possibly meningitis is simply blood culture and LP. is the practicality as well as some blood parameters. We would never do a routine super.
Sorry, I'm puzzled. So he have to have a neurological manifestation before doing LB, or just pure sepsis? Child is not doing well.
I mean, it depends. It depends. Are you talking about a baby that just comes into your unit, or a baby that's
Yes.
1 week old or 3 weeks old?
All of them. If we're suspecting general sepsis, we're not suspecting now that the child have meningitis. Do you usually do routine LB for every child before starting antibiotics?
It's not every child, no. And there is a debate which protocol you follow, because the AAP is different from the NICE guideline, and so we have some debates about when to do LP. Certainly, if a baby has some neurological manifestations, the baby will get an LP, no doubt. Any change in consciousness, the baby gets an LP. But if a baby is a routine septic screen because of risk factors, there's no LP. But if a baby is unwell with sepsis, it gets an LP. I think you have to take each one in context. But it's not a routine thing for a baby that's being screened, no. But a baby that's been with us for a longer time, yes. A baby that comes out in pus and a soup and is stinking and smelling, yes, gets everything. Not suprapubic, though. We don't do that. But not an easy answer, I'm afraid.
Thank you.
Thank you very much.